Hello, everyone. This is sorry, hang on a second. Hello, everyone. This is Dr. Siddharth Bomber. Let me just get rid of this echo. Hang on one second. Okay, everyone. Hi. Okay, great. Hello, this is Dr. Siddharth Bomber from Chicago Arthritis and Regenerative Medicine. I hope our audio issues are handled. Welcome to our webinar today. Today, we're talking about regenerative medicine treatments. As I am talking, please enter in your questions and I'll make sure that I answer as we're going along. So today we are talking about regenerative medicine, and here's what you should expect from this webinar. You'll learn about non-surgical treatments for arthritis and tendonitis that do not require surgery. This includes treatments like prolotherapy, platelet-rich plasma, and bone marrow-derived stem cells. What is legitimate in the field of regenerative medicine, and how you can choose the right physician and clinic for your regenerative medicine treatment process. And again, after we're done, you can always check us out at chicagoarthritis.com or any of our social media sites. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in again? So briefly, who am I? My name is Siddharth Bomber, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, regenerative medicine, and image-guided musculoskeletal injections. In practice since 2008, involved in regenerative medicine since 2008, and part of the Regenix Network, which is the largest network of affiliated physicians working in regenerative medicine since 2012. My own personal journey into regen med really starts with my own shoulder. I played a lot of racket sports when I was a teenager. Didn't really have any shoulder problems at that time. As I got older in my medical training, I learned how to do musculoskeletal ultrasound. This is now in my early 30s, start to realize I had some chronic injuries to my right shoulder that really weren't painful at that time. But as I got older and was then participating in more racket sports again as an adult, I started having some shoulder issues. So start to realize, because of ultrasound, that there are a lot of soft tissue injuries, things like tendons and ligaments, that were really being not appropriately or not fully treated as they should be, and realizing that we need to have better options. And in that process, through ultrasound training and meeting people, start to realize that there are other options, things like prolotherapy, platelet-rich plasma for some of these injuries, and then realizing the scope of how that could help out my patients as well. So there's a lot of flaws with traditional care. Traditional care for things like tendon, ligaments, arthritis, back pain is very much mask the pain, wait for eventual surgery. The example of that in, let's say, diabetes and other aspects of care would be, well, you've had diabetes, why don't you wait for your first heart attack before you do something to really try to fix or prevent this from progressing? So there's a lot of problems with that, obviously. The traditional pain medications don't fix the problem. They do have side effects. Traditional injections like steroid injections and nerve blocks or radiofrequency ablation injections, they help temporarily. They have a lot of potential side effects. They're not really working on the cause of the problem. Surgery has its role in more advanced issues and in the right cases. But surgery, as compared to non-surgical treatments, including injection treatments, is higher risk. A lot of common surgeries like knee arthroscopy surgery, if you already have arthritis, have been shown to not offer any more beneficial effect than just physical therapy or sham surgery. And in fact, it can lead to more progressive instability, which can then lead to more arthritis and more rapid progress on the way to knee replacement surgery. And so for those of us involved in Regen Med who do this seriously and appropriately, really strongly feel that 80% of what we're doing, 80% of the musculoskeletal conditions that are out there will eventually be able to avoid surgery. In the same way that what used to be handled predominantly with open cardiac surgery is now handled with medications, lifestyle changes, and needle-based procedures. So in searching for better options, we need options that are lower risk to avoid serious side effects. They should address the source of the problem, which is instability and inflammation, which I'll talk about in a bit. And they should actually focus on the cause of the problem, the root of the problem, and give you longer-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery and pain medications.
This meeting is being recorded.
And again, as we're going through this webinar, please leave your questions and I'll make sure to answer them. Okay, so let's talk about what exactly is regenerative medicine. So regenerative medicine is a process of using your body's own cells to treat arthritis, tendinitis, injuries, and back pain. The normal healing process after, let's say, even something mild like a cut on the finger starts with the following. Platelets come in, they first stop the bleeding, they then release growth factors. Those growth factors then stimulate your own stem cells locally. Your stem cells then start releasing other growth factors to bring in other cells and other cytokines. That creates some inflammation temporarily, which then starts that normal cellular repair process. This works great for tissues with good blood supply. For tissues with poor blood supply, they tend not to heal as well on their own. That includes your tendons, cartilage, ligaments, discs, labrum, and menisci. The thing is that those tissues are hardy in the sense that they can take a lot of damage or a lot of stress rather. But the problem is if they've been recurrently injured or if they have been too severely injured, they tend not to heal very well on their own. So regenerative medicine is a process of taking those same cells that are involved in your normal healing process, your platelets and your bone marrow stem cells, and then under very precise image guidance, injecting that into the damaged tissue to start the normal healing process. So why regenerative medicine? To begin with, it treats the source of the problem. Again, I'll talk about that more, instability and inflammation. It's certainly safer than surgery and effective for most musculoskeletal conditions, and I'll talk about which ones are appropriate and which ones may not be appropriate. So regenerative medicine works because it takes your cells in a joint or a tendon that have been chronically damaged, that's no longer functioning well. The cells in that joint or tendon are no longer pumping out the right proteins or enzymes for a healthy joint. That leads to chronic inflammation. So we can help to optimize those cells so that they're now functioning more appropriately. So longer term, less inflammation around those cells. Number two, we end up treating also the soft tissue elements around that area, ligaments, tendons, muscles. What happens is that you get a overall stronger functional unit, which then leads to better function and better pain relief long-term as well. In addition, our treatments do help reduce chronic inflammation, and we can also end up treating things like the nerves and other muscular structures as well to overall improve the functioning of that joint and tendon also. So what makes a regenerative medicine expert? It's a very busy slide, but the point is there's a lot. So, and I'm putting this out because, as with any specialist in medicine, to be a proper specialist, you have to be able to be very fine-tuned and an expert in a lot of different things. Unfortunately, what you'll find, at least in Regen Med, is that not everyone who's involved in this is a proper expert. So here's what you need to be. Number one, you need to be a musculoskeletal expert. What that means is your practice, your training, your work has to be focused on joints and tendons. If you're a physician who is seeing high blood pressure in one room, you're treating somebody's erectile dysfunction in another room, their low testosterone in another room, and jumping in to treat your knee or your back, that's not really the right way to do this. That's not a proper expert. Number two, they should be a non-surgical musculoskeletal expert. Our surgical colleagues, orthopedic surgeons, they're trained very well on surgery. They do not have all the requisite skills to do these kind of procedures properly. That includes things like image guidance. You need that for all procedures. Your physician should not be just palpating the skin and the joint and then just blindly injecting. You can do that with steroids, but you cannot do that with cells, with these kind of cellular treatments. The reason why is because you have to be precisely in the right location, down to a sub-millimeter level to make sure you're getting the right kind of outcome. The next one is they need to understand how to use inflammation to help you heal. You do get more inflammation for the first few days after these treatments. I find a lot of my colleagues, especially on the pain management side, will use a lot of steroid injections as their first-line treatment. If you think about this from a practical standpoint, if the goal is to help your body to heal from an injury, and if you're pumping somebody with steroids and you're short-circuiting their normal healing process, you're not giving them the best chance to get a longer-term healing response. And so if your physician is offering steroid injections first and foremost, and you have more of a wear and tear kind of issue, then you're not getting the right treatment. They're not doing this properly. They should be offering you a Regen Med treatment first line. The next issue is that you'll find some physicians who take the approach that they've got a particular kit, a particular machine in the office, and that's what they use for all their Regen Med procedures. That doesn't make sense. You may have a joint issue, the next patient may have a tendon issue, the next patient may have a ligament issue. All these are very different. You might be 80 years old, another person might be 30 years old, you might have diabetes and high blood pressure, another person may have nothing. You cannot have a one-size-fits-all treatment. And that happens a lot with these treatments because the physicians don't either have the capability or they don't have the understanding that you can tailor the treatments to what your problem is. So you have to be able to have a personalized treatment approach. There should never be a one-size generic kind of approach. The next is they need to understand the concept of prolotherapy or instability. I'll talk about that a little bit more, but important key part of Regen Med is utilizing prolotherapy techniques, which we'll talk about how do you treat instability. The next is they need to be very clear about what is your candidacy for treatment. Are you good, fair, or poor? And what does that mean in terms of expected outcome? I see this all the time. Patients who've been seen by other physicians, who've been given recommendations, and I'll see them and I'll say, you're actually a pretty good candidate for treatment, but their other physician has kind of just shrugged their shoulders and said, they're not sure, but you could try it. Or I've seen patients where they've been told, yep, try this treatment. And I'm telling them, actually, you're kind of a poor candidate for treatment. And let's explain what that means. So your physician should have that knowledge as well. They should be willing to follow your results long-term. They should not be just you come in for a procedure and you never see the doctor again. That's not appropriate. And they should be knowledgeable enough, experienced enough where they can guide you through the process. So yeah, there's a lot. So let's talk about some basics of Regen Med. Is this legal? Absolutely. There's some very clear-cut, strict rules that the FDA has now. And that includes things like you need to be using your own cells and not somebody else's. You need to be processing and re-injecting the cells on the same day, cannot be saving them. And then lastly, you need to be using this for musculoskeletal conditions, orthopedic conditions. Should not be treating things like autism, heart issues, kidney issues. There may be validity to all those things, but that's not where the science is right now. That's not what we're allowed to do in this country right now. Next common question or kind of FAQ, I'll hear patients say, if I'm older, should I use somebody else's cells? They've been told that. That's not true. When you look at the vast majority of orthopedic conditions, there's good evidence that using your own living cells is effective. That's what the data says, the research says. Next is there an age limit? Strictly speaking, no for most areas. The one exception are hips. If you've got hip arthritis, if it's more than moderate level hip arthritis, you have reduced range of motion, and if your age is over 65, then that could be an age limit to getting a good outcome. For everything else that we treat, age is not an impact in terms of how you'll do. That's important to understand because, yeah, absolutely, it'd be great if we were all still 25 years old and we could heal as quickly and bounce back from injuries. But the reality is that that's not the case. But when you look at the studies and when you look at physician outcomes from treatments, you'll find that age does not make a difference for the majority of things that we treat. What does make a difference is what's the level of arthritis, what's the joint that we're treating, what's your functional status, what other medical issues do you have. So there's other things to look at, but strictly speaking, age is not one of them. Again, what sort of doctor does these treatments? I just talked about the 2 slides ago. There's a lot of different things that your physician needs to be a proper expert on. If your physician is dabbling in this, that's not the right way to do this. As a physician, it's not the right way to treat your body. You really should be seeing an expert. Can you have these treatments if you already had surgery? Simple answer is yes. The exception is if the joint's been replaced. If you've got metal or hardware in the joint, you can't reverse that. And that you may still have other issues that could be treated, but if you've had hardware in the joint, then that's a different problem. But otherwise, we can still treat if you've had surgery. The general rules that I recommend my patients for orthopedic surgeries is, if possible, keep your anatomy. Avoid surgeries that are only cutting out tissue and not fixing anything. For example, knee arthritis, and if you've got arthroscopy. And then always consider a regen med option if you've been recommended surgery. May not be an appropriate candidate, but it's always worthwhile getting an opinion. So we're going to talk about some key regen med concepts. Prolotherapy and stability is the first one. There's this concept in architecture called tensegrity. And what it means is that if you take individual subunits that are weak on their own, if you put them in close approximation and compress them, you have an overall structure that is dramatically stronger. So the same concept exists in biology that's called biotensegrity. And I'll give an example of that. But so the concept of prolotherapy is that if you inject your own cells into soft tissue supportive structures, you can strengthen them more and stabilize them more, leading to an overall joint that is stronger than if you're only just treating the joint itself. The key here is you have to treat all the different layers that are involved and up and down from the joint that's affected. When you do this, you'll get progressive strengthening over time, and you'll get longer lasting results over time as well. So as an example, if you're treating somebody's knee, it's not enough to just inject into their joint. You have to treat everything else around that. So that includes the ligaments, the tendons, any of the fascial layers, sometimes the nerves, sometimes the bone. So you have to treat everything else that's really driving this chronic degenerative process. I see some colleagues where they'll say that, where a patient will say that they were treated with let's say platelets or prolotherapy or stem cells, and you'll realize that they only injected into the joint. They didn't treat all those other tissues, and that's why a person got a limited response, because their physician really didn't treat it adequately. So prolotherapy as a concept and as treatment is interesting. As a concept, it means strengthening those soft tissue structures to optimize the overall joint functional unit, gives you better results. As a treatment, there's sort of basic prolotherapy where we use dextrose, which is a concentration of sugar water, which creates mild inflammation. That sort of kickstarts a normal healing process. That's really the original regenerative medicine treatment that's been around for decades, since probably the 1950s. Then there's a more advanced version of that where now we're using your own cells. So regenerative medicine, there's a wide spectrum of kind of treatments that we'll do. So for prolotherapy, it's a milder treatment. In general, you'll need monthly treatments for 3 to 6 treatments. I'll generally recommend the patients do a series of 3 prolotherapy treatments, and then let's reassess after a couple of months to see how you're doing, to see if we need to do more. For PRP, on the other hand, that's platelet-rich plasma, stronger treatment. Now we're doing treatment on day 1, and we're seeing how you do for the next 6, even up to 12 months to see if we have to do another treatment. And then you'll see bone marrow-derived stem cells, where now you'll treat somebody in day one, and now you'll tell them, let's see how you do for the next 2 to 5 years. So there's a different degree of strength for these treatments. Depending on your issue, one or the other may be more appropriate. This is a case study for the prolotherapy concept, where it's a patient with lower back pain. They've had laminectomy surgery in the past. This is an example of where you can still treat somebody after surgery. The prolotherapy way of treating this, and we use his own platelets for this, we treated the ligaments, the facet joints, the muscles, the epidural space, really treating the complete spinal functional unit. He had about 30% pain relief several months down the line. Because he's had the surgery, we decided to escalate to something stronger. We ended up using his own bone marrow stem cells here, stronger treatment option, and he had a better response. But again, treating all the different layers of treatment. What I like about this kind of example is we're treating in a prolotherapy style all the elements of the functional unit. We're utilizing platelets, and then if needed, we're even escalating the bone marrow and getting a good result. So leads us to orthobiologics. Orthobiologics are the biologic cells and tissues that we inject into damaged orthopedic tissue. As I mentioned, this uses your normal healing process, and I would strongly recommend you utilize your own cells for a couple of reasons. Number one, that is what's legally allowed in America. If you see anybody utilizing, let's say, placental or amniotic cells in this country, there's no living cells in that, the way it's processed. So you're not getting like a proper stem cell treatment there. If you're using your own stem cells or platelets, you should be using your own cells. You can go to other parts of the world and get other people's cells. You have to decide if that makes sense to you or not. You should know that the overwhelming research and studies on this are done using your own cells in the world. And so stick with your own cells. I would recommend that. You don't have any of the rejection risks. You don't have any of those other kind of risks. Platelets are really our first line orthobiologic I want to talk about. As I mentioned before, after an injury, your platelets are the ones that sort of kick off that normal healing process, starting with inflammation. They work by stimulating your own local stem cells. So there's different types of platelets, all right? And this is important for a few reasons. So the picture on the right, you have two different platelet preparations here. The one with the red blood cells, and there's one without any red blood cells. That's the one on the left that's yellow color or amber color. The one with the red blood cells is more inflammatory. You can utilize that for muscles. I'd be careful about utilizing that for tendons and joints because it's more inflammatory. You can get the same long-term result using the amber colored one without the same level of inflammation. There's other types of platelets like platelet lysate, where we take the platelets, crack them open, take the growth factors, inject that around the nerves. It's less inflammatory, it's quicker acting, less inflammatory, better for nerves, and we'll utilize that for nerve issues. Another key thing to understand is you'll hear physicians utilizing platelets differently. I've heard of physicians utilizing platelets, let's say for knee arthritis, utilizing it once per week for 3 to 5 treatments. And we'll tell patients, well, get treatment on day one, let's see how you do for the next 3 to 6 months. Why such a difference? So the folks who are doing like repeat treatments once per week for 3 weeks, they're using a very low concentration of platelets. The reason why is because that's what they have access to. That's the technique that they're using to prep the cells. You know that because they're taking out 1 or 2 tubes of blood. They're repeating treatment very quickly. The data shows if you use a higher concentration of platelets, you get a better long-term result. So for a higher concentration of platelets, let's say for a knee, we'll be taking out 10 to 15 tubes of blood, right? Because that's how you get a higher concentration, just by having more blood. When you do that, there'll be a little bit more inflammation for the first couple of days, but then you get a longer lasting, better result long-term. That's what I would recommend. And so if your physician is recommending repeat treatment once per week, they're utilizing a low quality, low concentration of platelets. You can tell that they probably don't exactly know what they don't know here, right? That they should be utilizing a better technique. As I mentioned, the concentration varies. We'll generally utilize a very high concentration for joints, a medium concentration of platelets for tendons, and maybe a lower concentration for ligaments. So you have to have that flexibility to manipulate that. Most physicians don't. They're just using like a one-size-fits-all, but if you can manipulate it, you'll get a better result for you. It's a nice PRP sort of case study. This is a individual referred to me by a sports medicine doctor. He's a regular guy, 45-year-old man, but he does do a lot of cycling and he does a lot of cycling. So he had left knee patellar tendonitis. On the picture on the right, that is a picture of an ultrasound showing the patellar tendon. The bright white line is a kneecap. I don't know if you can see my cursor, but the tendon is outlined here. And at the kneecap, you see a little bit of tendon spurring at the tendon as well. So he had failed physical therapy, still having pain. We ended up doing platelet-rich plasma 2 times in his case over a few months. The picture on the right here, again, is ultrasound. That's the needle injecting into the patellar tendon. Important to do this under ultrasound guidance because that's how we know we're hitting the right tissue. After 2 treatments, after a few months, he's back to his full activity. I then saw him 3 years later. Now his other leg, he now had a hamstring tendon injury. Again, treated him with platelets, and he's doing great. What I like about this case study is how, number 1, repeating treatment makes a difference. Number 2, platelets are a great first-line option. And number 3, how we can treat one area one time and then treat another area down the line and still get a great result. The next type of orthobiologic to be aware of are stem cells. These are the main cell that drives tissue repair after an injury. Again, utilize your own cells, please, not somebody else's. That's what's safe. That's what's legally allowable. That's where all the data is. In the United States, bone marrow-derived stem cells are the only ones that are legally allowed. You may hear, probably not any longer, but in the past, you'd hear people utilizing fat or adipose cells. Understand that if you're utilizing it as a stem cell treatment, that is considered illegal in the US. The FDA feels that the enzyme that you use to break down the fat cells may not be safe in humans. You can use fat and adipose without that enzyme, and you're using it more for structural support. Let's say someone's got a bad tendon injury. You want to inject their platelets or bone marrow cells, but you end up using some of the adipose or fat cells just as like a fat graft a little bit. And then you're layering the cells on top of that. It helps to keep the cells in that area. That's a good use of fat in that case. Again, you may hear about amniotic and umbilical cord cells. There's no living cells in those products in America. Because in order to be sold off the shelf in America to physicians' offices, they need to go through a processing steps that basically kills off all the cells. You may hear about utilizing umbilical or amniotic cells, living cells in other countries. Again, very little evidence or data rather of the safety of that long term. Sort of buyer beware there. IV stem cells, again, no proven benefit for orthopedic conditions. If you take somebody's blood or bone marrow, concentrate it, and then put it back into their IV, into their veins, understand that that goes right back through your lungs, and what happens on the way to the heart to then get pumped out into the arteries throughout the body. And as it goes through the lungs, it'll basically get caught within the normal kind of process where it doesn't actually get to the rest of your body. You may get a little bit of anti-inflammatory effect from that, but no proven benefit specifically for osteoarthritis and tendonitis. When it comes to regenerative medicine treatments, there's a lot when it comes to decision-making, and I think your physician should be having these conversations with you. Number 1, they need to be thinking about what's the severity of your issue, right? Is it like, how do we decide which treatment to use? Depends on a few things. What's the severity of your issue? Are there any medical contraindications? So let's say you have a recent history of cancer. You'd want to be careful about utilizing your own stem cells, right? There's no evidence that that's unsafe, but I would be cautious. Let's say you're on high-dose steroids. Doesn't make sense to utilize your own stem cells or platelets because the steroids will kind of minimize that. Maybe prolotherapy is appropriate at that moment until your overall medical condition improves. Understand also that you may get one treatment on day 1. A year, 2 years later, you may get a booster treatment from another cell treatment. So for example, you may get, let's say, a stem cell treatment for your knee. You're doing pretty well. You're a year and a half, 2 years out, and you're at maybe 65, 70% improvement, and you're hoping to get a little bit further. You're kind of stuck at that level. A platelet booster would be a good option there. Understand there's cost differences between which treatments that you utilize as well. And so you kind of have to consider all of these things when it comes to deciding what's the right treatment for you. I think if you're someone who cannot utilize bone marrow or platelets for any reason, you could still benefit from prolotherapy, just it'll take more treatments to kind of catch up to that. And again, what generally takes 3 prolotherapy treatments is what can be achieved with 1 PRP treatment, and what can be achieved with maybe 2 to 3 PRP treatments is what can be achieved with, let's say, 1 bone marrow treatment. So that's kind of how you think about these things. When it comes to outcomes with stem cells, important things to understand. So yes, we can improve your pain and function even if you've got an advanced case. There are exceptions to that. If you've got more advanced hip arthritis, much more challenging. I would generally refer those people directly to surgery. But if you've got advanced knee arthritis, that can still improve. All right. And so you'll hear physicians that'll say, no, that cannot improve. And I'll talk about that in a moment, but the data shows that can still improve in terms of pain and function. On the other hand, can we improve how your X-ray and MRI images look? So if you've got an advanced level of arthritis where there's a lot of joint space narrowing, I cannot reverse that 20, 30 years worth of damage in terms of getting your images to look different. We can dramatically improve your pain and function and quality of life, but cannot necessarily improve how the images look. On the other end, let's say you have swelling in the joint because of advanced arthritis. We can get that to dramatically improve. That can improve on images. If you have a tendon or ligament tear that's less than 2 centimeters in diameter, we can actually improve that on images as well. Or if you have early avascular necrosis where the bone is starting to get damaged, we can improve that as well. And I'll show images of that. Can we treat bone-on-bone arthritis? This term bone-on-bone is a really bad term. In some cases, it's accurate in the sense that, okay, you can't move the joint. But frequently, I'll hear people have been told by their physicians or orthopedic surgeons that they have bone-on-bone knee arthritis, and yet they're still bending their knee almost fully normally. That's an example of where you obviously don't have, it's not literally bone-on-bone. It's just significantly narrowed if you've got that kind of range of motion. But more importantly, understand that arthritis is not just a picture on the wall. It's a biologic condition that's treated with biologic treatments. And so if your range of motion is still pretty good, if your function is still fairly intact, good outcomes are still expected. I keep on saying this, but the one caveat is advanced hip osteoarthritis is challenging. If you do have more advanced arthritis in general, again, we can still improve pain and function, but improving imaging is unlikely. Another good question is, well, what about tendon and ligament tears? What can we do for that? So I like this as a case study. This is, we can definitely improve partial thickness tears, some full thickness tears as well. So if you have a tendon, if it's partially torn, let's say there's like half of it's missing, we can still improve that dramatically. If it's fully torn, if the tendon is fully pulled back, you really need surgery for that. All right. After surgery, you should think about getting your own bone marrow cells injected into that to maintain that long term. But if it's a full thickness tear and the sides are still close together, yeah, we can still actually improve that. This is an example of a 28-year-old man. He's a butcher. He's playing recreational volleyball, tore his ligament, his ACL. We ended up treating him within 2 months. And within 3 months, he had no pain, starting dynamic activity with PT. And I'll show you his images, which is great. The images here that you see on this slide, this is a knee x-ray, the side view. It's the kneecap, thigh bone, shin bone. There's a needle coming in, and what's lighting up in the center of the knee is the ACL. You can only do an ACL injection under high-level fluoroscopic guidance. Definitely cannot do it under blindly injecting, and ultrasound's not adequate either. So what's nice about this is he had not only a great clinical response, he has an amazing imaging response. So his MRI image on the left, that's pre-treatment. Again, I'm not sure if you can see my cursor, but you have a very hazy looking ACL, a fully torn ACL. There's edges are still close together, but there's a lot of haziness here. 3 months later after treatment, you now have an ACL that looks, for all intents and purposes, back to normal. Still a little bit of swelling from the treatment, but the ligament itself is fully intact, has a very nice linear structure, and looks essentially back to normal. So that's a great result of not only improvement in pain, but also improvement in function and imaging. It's a nice study of a patient of mine, general contractor, does a lot of overhead activity as part of his work, had a tear, probably a chronic tear that became a full tear of his right shoulder, his dominant hand. The ultrasound images on the left, this is his pre-treatment. What you see is a tendon and then like a hole in the tendon right where it inserts. That's a good sized tear. So he had his own bone marrow cells injected. And 3 months later, under ultrasound, what you see is that hole is now filled in. That's pretty exciting. So great clinical result in terms of no more pain and getting back to activity. But what's really great is also the actual images look nice as well. Again, please type in your questions. We'll make sure that we kind of answer them as we're going along here. The next concept to discuss is interventional orthopedics. Your physician really needs to be utilizing image guidance for all their procedures. And the reason why is because you cannot be just close to where you need to be. You need to be exactly where you need to be when you're injecting cells. Picture on the left is an ultrasound image. This is the needle. It says needle on it. We're injecting a very small little area. This is 1 millimeter by 1 millimeter. To do that, tear in the rotator cuff tendon. To do that, you have to be very precise with your image guidance. Image on the right is, again, injecting into the shoulder. There's a needle. You see a line that kind of lights up in the joint. That's how we know we're injecting into the joint. What's cool is there's also a little line we injected in the triangular structure where we inject into labrum as well. To inject the labrum, you cannot do that under ultrasound or under blind, just palpation. You have to really be on top of it with fluoroscopic guidance. So image guidance is key. This is images of the knee. I showed this before. Image on the left is injecting into the patellar tendon. Image on the right is injecting into the ACL. It's a case study of ankle avascular necrosis. It's a 41-year-old chef. He's on his feet for 12, 13 hours per day, having a lot of pain. His MRI on the left pre-treatment shows arthritis, fluid in the joint. He's also got swelling in the bone from early avascular necrosis. If we don't treat that swelling in the bone, he will have progressive damage to the joint itself. So we injected cells into the joint, into the ligaments, and into the bone. 3 months later, doing well. Images show no more fluid. Images show no more swelling in the bone. Doing fantastic. He's now several years out and doing very well. So regenerative medicine treatments offer safe and effective solutions for your pain. Okay, it's a good question. Just looking at some questions here. It's an interesting question about blood flow and diabetes. You know, diabetes is one of those conditions where if you have chronic, poorly controlled diabetes, or if you've got type 1 diabetes, then there's a risk for damage to the small nerve fibers, and there's a chance for damage to some of the blood vessels as well. From a treatment standpoint, if your diabetes is well controlled, there is no limitation to proceeding with regen med treatment. If your diabetes is poorly controlled, and frankly, I would say this for any condition, if your overall health is poorly controlled, I would always recommend optimizing that before you proceed with one of these kind of treatments, in large part because that's how you'll get a better result. So, is this too good to be true? Here's where the evidence is. So there's evidence for these treatments that goes back to the mid-1990s. There's actually physicians who've been doing prolotherapy, dextrose prolotherapy, old school, since the 1950s. But in the more modern times, you have Philip Hernigue, a French surgeon who has data since the 1990s, and Regenix Networks has data since 2005. Philip Hernigue actually has patients that he treated for knee arthritis and shoulder arthritis. He has patients, a cohort of patients where he treated one side with surgery and the other side with bone marrow cells. And what he found was that there was a similar response in terms of pain relief and functional improvement. The main benefit of avoiding surgery was that the range of motion and activity was better preserved if they could avoid surgery. So this field is rapidly developing, but it's not new. I have personal experience since 2008. I have colleagues who 10 years ago were telling their patients they thought these treatments didn't work. 5 years ago, they were telling patients they weren't sure, and now they're telling patients they think it might work, they're not exactly sure, but they'll treat them, and they're not the expert. The bottom line is that the field is not new. There's right and wrong ways to do this. You need to have expectations that are grounded in reality and evidence-based medicine, and your physician should be able to guide you through that properly. If they're not, then they're not doing their duty properly. How long do results last? Regenix has data that goes, this goes back to 2005 now. So actually 20 years. Philip Pernicue has data that goes even more than that. What I still tell people is if you have a chronic condition, think conservatively, expect that a repeat treatment may be needed a few years after your initial treatment. If you're getting, let's say, platelets, you may need to get a repeat treatment 1, 2, or 3 years down the line, depending on severity. If you're using bone marrow, expect that you'll get improvement for 5 years. You may need a booster treatment at some point. That may not be as involved as that initial treatment, but what we know is that people will get a slower improvement over several months, or for bone marrow for a year. They'll then sort of stay at this higher threshold for some time. If they start to dip down, if they need to repeat treatment or a booster treatment, you're now still starting at a higher level. You're not starting back at baseline, and now you're kind of getting them back on track. So that is an advantage of these treatments compared to some of the more traditional ways of treating this non-surgically. Some of the best ways to maintain results after treatment, what I would recommend are improve your biomechanics, work with physical therapy, your trainer, use the appropriate joint supplements. Repeat treatment, as I mentioned, is additive to that initial treatment because people tend to stay and hang out at that higher level longer term. Maintain your ideal body weight especially if you have lower extremity or back arthritis. That can be helpful just in terms of reducing not only stress on the joints from like a weight standpoint, but also by improving overall inflammation and metabolic health. Sort of showing this slide again, what makes a regenerative medicine expert? It's a lot of things. The bottom line is that your physician and clinic, as a patient, you should be expecting the best, and they should be offering you their best options first and foremost. That may not be the right option for everyone, but they should be at least discussing that with you, and they should be folks who have a lot of experience. You don't want to be someone's first 10 patients, even the first 100 patients. You really want to be working with an expert where you are their 5,000 patient or 10,000 patients, where you don't ever want to say things are routine because each patient's different and you should always be taking things very seriously. But it should be to the point where they're doing so many of them that it has become routine to them. It's a little bit more about us when it comes to, I see the question. I will make sure that we get to these for sure. So just a little bit more about us here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, starting by evaluating to see if you have any inflammation, instability, asymmetry, neuromuscular issues, trying to correct with low-risk interventions first and foremost. If that's not working, then escalating to next steps. If appropriate, that includes regen med treatments, utilizing the highest quality products from your own body, a plan that is specifically tailored for your condition, and delivering cells using the highest level of image guidance as well. I'm going to get to your questions. How to get evaluated? You can just go to our website, chicagoarthritis.com. In the chat section, I left the email, admin@chicagoarthritis.com, or even the phone number if you want to get a hold of us. But plenty of ways to connect with us. Let's start getting some more of these questions. So in terms of age limit, there's really no age limit. I mentioned that for hips, age can be an issue, and you have to keep that in mind. But in general, for most other areas, there's no real limit based on age. More based on what's your degree of pathology and what other medical issues that you have. Blood thinners, depends on what areas that we're treating. I would generally recommend holding your blood thinners before a procedure. There's some areas, like let's say we're treating the knee. If you're getting, let's say, platelets or prolotherapy, you're not going to bleed that much. The exceptions would be if we're treating, let's say, the bone, then I would ask you to hold your blood thinner. For most of the modern blood thinners, you can hold them the day of procedure and then restart them the next day. That's not such a big deal. If you're getting a bone marrow aspiration, would definitely recommend you hold your blood thinner on that day just for safety purposes. Somebody asking about success rate depends on which area that we're treating. So for example, if we're treating, let's say, a knee arthritis, regardless of your level of degree of knee arthritis, what we know is for bone marrow, your percentage improvement at the 1 and 2 year mark is on average 65 to 70%. Talked about age limit. We talked about blood thinners. We talked about AFib. Someone was asking about atrial fibrillation if they're on blood thinners. Again, generally we can work around that as well. Okay, good. Other questions for me at this time? Okay, great. If there's no other questions currently, we're going to wrap things up. Thank you, everyone, for your time. Thank you for the questions. And if you've missed any part of this, you'll get a replay. You can watch that. And great, you're welcome. You can share this with anyone else who might benefit from this. But until we connect again, I hope everyone stays healthy and live well. Bye-bye.